Hey y'all, we are back with part 2 of our conversation with Dr. Theo Hodge Jr., a PreP expert and well-known infectious disease specialist and practitioner based in my very own Washington, D.C. You can check out part 1 of this His Health podcast on our feed. So during today's discussion, Dr. Hodge goes in depth about his sentiment on why there's been such an uneven uptake of PreP among Black gay men as compared to white gay men. We also talk about how the tide is turning on this front, as well as CDC screening and PreP guidelines and why it's important for all healthcare providers, whether you're an infectious disease doctor or working in primary care, to offer universal education about PreP to their patients. After listening in on today's podcast, go to hishealth.org and take Dr. Hodge's 1-hour continuing medical education course on, you guessed it, all things PreP. Just click on the Continue Education tab on the home screen and go for it. All right, y'all, let's get into it. And I love that you're hitting on the head the whole point of what we're trying to do at His Health, which is sort of humanize and fully realize that providers are people who have their own biases and shortcomings, and you're talking about sort of your own personal process over the years of addressing that. And I want to talk about that with regard to PreP, because you're the kind of the PreP master in DC and sort of everywhere.
Like PreP is all about PreP.
I know you're like tired of being like hitting the PreP button behind you.
No, I love PreP. I can talk about PreP.
So there's some practitioners who might refrain from prescribing PreP or from sharing information about PreP, whether a patient, is interested in it or not, because they don't necessarily want to see themselves as enablers to quote unquote risky behavior or what have you. And for those who can't see, Dr. Hodge is giving the epic eye roll, which is appropriate.
Child, please.
Tell us the truth about how to share information about PreP, when to share information about PreP, and why you should sort of follow a process as a provider.
So, as a provider, for me, the perfect opportunity to approach the topic of PreP comes during the physical exam. So in my office, and I am in a private practice and in a public health clinic, I'm an HIV consultant for a public health clinic. So, but in my private practice, I do physicals. Physicals is, physicals day in, day out. Mm-hmm. And during a physical, there is always, you reach the point of a sexual history. Well, many of my colleagues, they can't even begin to ask you about sex. And I'm like, what's up? What, you're supposed to be enhancing and partnering with this person to enhance their medical health. What do you mean you can't ask them about sex? Do you really think they're not having any? So it's during the sexual history where you're asking people, well, do you have sex with men, women, both, blow-up dolls, whatever. So, I mean, you need to ask because,
you'll never know.
You never know. And, if you are having, sex, is it condom sex or is it condomless sex? And if you're having sex with men, what position are you playing in? Are you in a monogamous relationship? And have you had any history of sexually transmitted infections? Ding, 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 as you're going through what's an appropriate candidate for PreP. And after you've asked all those questions, whether or not the patient is going to be an appropriate candidate will definitely rear its head if they say, oh, well, I had chlamydia and gonorrhea, and I just got over syphilis, and then yes, I've had, because one of the questions is how many sexual partners have you had over the last year? And if they say 500, then okay. And then the next question is how many sexual partners have you had ever in life? Well, in my practice, the highest 6,000. So I tell people that all the time because they're all embarrassed. Oh my God, ooh. I'm like, well, the highest is 6,000. And they're like, oh, okay. Well, I'm definitely exactly. Oh,
4,312.
Right, there you go. So it is during a sexual history I think is the most appropriate time to bring up the subject of PreP. And almost all of my patients, once I say something about it, whether they know anything about it or not, when I say, well, there is a pill to prevent HIV, they're like, oh, really? Well, or they're like, okay, I know about that. That was one of the reasons why I did this physical, so that we could talk about that. So I think for my providers, for my colleagues, I should say, it's very important that they bring up, a potential option to prevent an incurable disease. We still have an epidemic, and certainly in the African American community, anyone who has seen any of the information about the epidemiology knows that we are disproportionately represented. outrageously disproportionately represented. And as I remind people all the time, yes, I know what it's like to be competitive. It's wonderful to win. This is not something we want to win. We do not want to win.
We don't want this medal. We don't want this award.
Exactly. We don't want it.
Yeah.
We don't want it.
Yeah.
And as a result, hey, colleagues of mine, we need to help take that medal away. And this is one way of doing it, simply by taking a history and bringing up a potential option to prevent a deadly disease.
What do you say to a provider who says, I already feel like I'm stigmatizing patients by constantly asking them about an HIV test? What do you say to providers who say, well, asking or offering information on PrEP could be potentially stigmatizing? I don't know how to work around that.
You know what? I would say, look, what? Stigmatizing? Really? What is your job as a healthcare professional here? It is to enhance the quality of life of your patient. Are you actually going to sit up in my face and tell me that by offering them the potential to prevent a deadly disease is going to stigmatize them? Really? Then you need to think a little harder about how you twist your language if you really feel you're presenting that way.
And you mean how you ask the question.
Exactly, because the problem is not with the patient, it's with you. And you need to get over yourself. Or, go get some education. I mean, we're always learning, and I'm not sitting, I tell people all the time, I'm always learning. Whenever I'm out talking, my audience always educates me on what's going on in their particular area. I mean, so, there's so many of my colleagues who feel that they really descended from the heavens and that there is nothing that I can tell them or anyone else can tell them because they know it all. Wrong. Get over yourself. You really have to remember what your job is. You are to enhance the care of that patient. Do it. Okay? No excuses, because people love making these excuses. Okay? This is behavior that you're responsible for. You are responsible for enhancing or presenting the options to enhance the care of your patients. If you don't, then you're irresponsible. That's my answer.
How do we, these things that you're saying, these are thorough threads that we've heard from other providers about saying, I'm coming to the space being clear about what I don't know. I'm comfortable sharing with the patient that, I want to know. I need to learn from you. What is your sort of guidance or feedback for providers who just aren't comfortable talking about sex? What?
Then send them to somebody who is, okay? And I tell the patients the same way. If you feel that you can't really talk to your healthcare provider about any and everything, you need to change healthcare providers. Now, I recognize, because, people will say, well, Dr. Hodge, that's so cute that you say that. Only one person here in the city I can go to. I'm
right.
Okay, well, then you're going to have to make a do. But it would be the same thing with the healthcare provider. And I'll give my colleagues credit, because occasionally they're like, I am not comfortable with this. You need to see another healthcare provider.
They'll just tell their patients.
They will tell their patients that. And I applaud them. I'm like, okay, if you're not comfortable with this, then send them to an infectious disease provider or someone else identified in the community that is comfortable with that. So I recognize that although I'm sitting here saying, people should get over it and just do it, in real life, there are people who are just not going to be comfortable with that. So at least be responsible enough to acknowledge it and send the patient somewhere else.
And that's an effective sort of tool or strategy that I feel like what you were talking about in terms of providers feeling like they have to be infallible and not, do all things. It can be a real option for you, and could be potentially very much life-saving for your patient. Cultural consideration. So and let's just sort of go back to maybe the root, right? So maybe some of your sentiments around gaps in terms of training for providers to get them there. What are some things that providers can do, provider workforces can do to sort of cultivate their sense of cultural competency when working with LGBT patients of color?
Well, it would be nice if they actually had training in some of the issues that LGBT folks have to endure, which would include stigma. I mean, they need to know, because so many times people just, just say, oh, well, you should just tell your pastor, you should just tell your mama about this. Somebody needs to know. And I'm like, you really?
Like it's a ABC after school special.
Right, exactly. Just tell them. I'm like,
no
really?
problems.
You really have to understand that this can cause, complete drama. People get thrown out of their houses. They get, the pastor jumping up in church saying you're going to bust hell wide open. Aunt Susie going, oh, my child, I can't believe this. My nephew is gay. I mean, all the drama that really, really happens. I mean, I tell people all the time, as a gay person, to have drummed in your head that your whole being is fundamentally wrong is an incredibly difficult thing to overcome. And so many of us don't. Mm-hmm. That's why you see people, the mental health things that come up, the substance abuses that come up, the other behaviors that land people in jail come up. I mean, all of these things come up as a result of many things, but certainly the whole drumming into your head that your whole being is fundamentally wrong. It's fundamental, damning. Right? Yeah. Fundamental. Your very core is wrong. That is what gay folks, many people, have had to deal with, and to overcome that is an incredible thing to do. But again, that process can be a long one, can be short for others, and for many others, it never happens.
Mm-hmm. I want to sort of dial back to what we were talking about earlier in terms of what inspired you and sort of what the landscape really was in HIV in the late 80s and the 90s to where it is now. You talked a lot about what's changed in terms of treatment therapies and all of the work you've done around awareness and education. What are some things that maybe have stayed the same? What are some things that haven't changed?
Well, that's a really good question. Some of the things that really haven't changed is pervasive ignorance about transmission. Mm-hmm. I am constantly stunned. In the circles I travel, we talk about transmission of HIV, and we talk about the 5 bodily fluids. And in 2016, I am so stunned at how many people will say to me, and even a healthcare provider, I was in Baton Rouge and I was doing my thing on HIV 101, and I was talking to a group of people that included the director of the clinic, who was a 34-year-old anesthesiologist. And I was like, oh, yeah. Name the 5 bodily fluids that transmit, and I made a big deal, transmit HIV. And out of her mouth came saliva. And so, of course, after I collapsed on the ground, laid out, people were like, oh my God, this child is on the ground. Because, I needed to make a statement. I mean, can you imagine somebody actually saying that? And as I laid on the ground, because I laid on the ground at least a whole minute, and people were freaking out because they really thought I had collapsed.
Oh, you really did? Right. I was just exaggerating.
Laid out. So, as I got up off the ground, people
my gosh.
Did that girl actually say saliva? She wasn't going to say it again because she was already mortified. But, and I said, no, this is not meant to call you out. It's really just to make the point. Because, you always have to be very careful.
Opportunity to educate.
Mm-hmm. Right, exactly. That you cannot actually tell a patient that saliva is going to transmit HIV. I mean, a mom is coming in with her 3 children, and you're telling her if she kisses her babies, she's going to give them HIV. You can't do that. It's not true. It is not one of the 5 bodily fluids. And then, of course, we go through the 5 bodily fluids. But to me, that hasn't changed. Ignorance is still pervasive about the simple transmission of HIV. The HIV 101 is still a pertinent educational program in 2016, and is even more so, I feel, than it was in 1980. People don't know.
Why? With it being around, it's been coming up on 3 decades.
You would think. You would really think. But I think people have become so complacent that they really haven't really paid attention. They just assume that they know, and they really don't. I'm shocked. I still have patients coming in. Again, it's all about education. Coming in with a drip, and I'm like, oh, okay, did you wear a condom? They're like, oh, God, of course, Dr. Hodge, I wear a condom.
And tell the listeners what you mean by a drip, because we've got all kinds of folks who are listening.
So a drip is, the patient's coming in, one of my male patients who's coming in with a penile discharge, and the penile discharge is usually going to be yellow, green, or white. And they're coming in because they're like, I don't want this anymore, and it hurts when I pee. So they have a sexually transmitted infection. And so, when we're talking about safer sex, we always talk about condoms. And many times my patients will come in and say, of course I wore a condom when I was engaged in anal sex. And the next question I ask is, well, what about when you received your blowjob? And of course they look at me and go, who does that?
Why would I wear that?
Right. Who wears a condom when they're getting a blowjob? And I'm like, you do realize that's the most common way that you come in here with a drip, because that infection is in the back of your partner's mouth. They're not going to know it. They don't have any symptoms. They're not deliberately trying to have you have yellow-green stuff coming out of your wee-wee. But that's how you got it. And again, clueless as to how this could have happened. Again, it's still, education is still, and I never get tired of it. I never get tired of educate. And it's across the board, my older people, my younger people, doesn't matter. People who think that they are not at risk for HIV, the CDC has said that everybody should get a test. Everybody. Regardless of risk. Everybody. Now, who gives me the hardest time? My women of color. Especially my older ones that are married. They look at me and they go,
what do you mean? I'm married.
I am married. My child is from Jack and Jill. My husband is a professor at Howard. Why would you think that I would ever be at risk?
Just routine.
I always remind, especially my women, because, here I am in Washington, D.C., so you know where they're coming from. So they're, they're on the Gold Coast, and of course they come into my office and they have this big diamond ring, and of course you're like, oh, you know they must do exercises to lift that ring. It's huge. It blinds you. It really does. So I always remind them, okay, did that ring fly off your hand, knock your man upside his head when he looked over the table at her or him? I just want to know. So,
What did it?
Right. And then they look at me and they go, do the test. So, they get it, that everybody should have a test regardless of risk. And then, of course, any further testing is based on risk.
Are you finding that also those are great opportunities to talk a little bit about PrEP as well?
Yes, I do. And I do talk about, now, granted, my African-American women who are in these long-term relationships, the question is, because, again, when we look at a CDC guidelines for the appropriateness of PrEP, she would not be considered that because she's supposedly in this monogamous relationship. But you get this HIV test, right, and if it's negative, then granted, I'm not going to be sitting there going, well, your man could be cheating. I'm not going to do that. Because she really, given the social history that you've taken, sexual history that you've taken,
and what you shared with me.
Right, and she has a negative HIV test, then there would be no reason for me to talk about PrEP. As opposed to the woman who is with her longtime boyfriend has come in with a sexually transmitted infection. That's totally different. And I always remind people that PrEP is for everybody. We're talking about men who have sex with men, and most definitely they are disproportionately represented in terms of HIV infection. But PrEP is for everyone. Men, women, straight, gay. And it is my African American women in particular, that look at me and go, really? I thought that PrEP was only for gay men.
The way that it's being marketed.
Right.
So if I'm hearing you right, it's about educating universally, prescribing somewhat selectively.
Exactly. Now, the messaging, you're right. I really think the strong messaging, you have to go after the communities that have all the HIV infection. So, of course, strong messaging and marching through African American gay men, large gatherings or organizations is important because these are the people who have HIV. But at the same time, it would be derelict for me as a healthcare provider to forget everybody else. Mm-hmm. Because there are people who are at risk. And I'm telling you, my female patients in particular, they're dating out here in Washington. I can't tell you how many of them I do have on PrEP. And how many of them look at me and go, I never knew that PrEP was really an option for me.
You do a lot around HIV 101. I want to talk to you a little bit about your experience with varying levels of awareness or understanding of PrEP, specifically amongst your Black patients, Black gay males specifically. And I hate to do sort of race comparison versus white men, gay men, because this is something that you and I have talked a lot about. Why is there a bit of a knowledge gap?
I think initially, that's a good question, is why there's a knowledge gap. I really think that, well, let me tell you, this is Dr. Hodge.
And things are rapidly, quote unquote, trying to change.
They're definitely changing, but this is Dr. Hodge's take on this.
Okay.
So I am part of Gilead. I'm actually part of Gilead's PrEP Speakers Bureau. But before I became part of it, and PrEP was being, they were selectively sending physicians out to talk about PrEP. The people that they sent out were gay white men. And they wondered why nobody would show up in the South. And, when I went out to the PrEP advisory board and I said, well, Black people don't know about PrEP, they looked at me and they go, everybody knows about PrEP. And I'm like, wait a minute. Do I see anything that looks up there? I mean, I really had to tell. And they were angry. People were mad. They looked at me like I was, who are you? You're not some major principal investigator. You mean you haven't published thousands of papers? Who are you to tell me that everybody doesn't know about PrEP? I said, let me see, because I actually work with patients, because all the slide sets that you give me to present to people say that it is in the African American community that HIV is present. And I'm telling you, since you clearly are not seeing these people, they don't know. So maybe you might listen. They did, but it took them a while. So remember, that meant essentially that gay white men were being messaged about PrEP, and they came running into my office. I can't tell you, Trevor and Skylar all knew
Bailey
about PrEP, and I'm serious, they were like, well, Trevor is on it, so I need to be on. That's exactly what happened. I was like, who are these people? Why? I mean, I was shocked. Because they were adamant. They were like, look, so-and-so. It reminded me of back in the day with ACT UP. Those people, they didn't play. They're like, we are dying. You will do something about it. We will smack you down. That's exactly what happened with PrEP.
It's interesting how the omission of information can be just as deadly as a situation like Tuskegee, where you are actively implanting poison into a marginalized community.
Exactly. So Malik didn't have a clue. Malik would come in, I'm like, hey, what about PrEP? He was like, who, what? There was no messaging in Malik's community. None. They didn't know about PrEP. That is why Malik didn't know about PrEP. Nobody was talking about PrEP. Trevor, people were talking about it. So, obviously, people jumped up and said, oh, no, Malik needs to know. And then, of course, Malik had a little trepidation because it's like, well, you're trying to get me to take a pill, blah, 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 blah. But with education, just like Trevor, Malik was like, this is an option that I really need to consider. It may be right for me. It may not be right for me. So that is my observation. And this is my clinical experience as to what happened in my office. PrEP was approved by the FDA in 2012. In 2013, Trevor and Skylar and Blake were all in my office. And Malik did not have a clue. It was not until late 2014 that Malik said, okay, I heard Jamar talk about this. Mm-hmm. And now in 2015, I see, I definitely, the huge difference in 2015 and 2016 in terms of people's knowledge about PrEP. So now it's my female patients. My gay patients tend to know. My men who have sex with men patients tend to know or have a clue. Not always and not all the time. And it's still, if someone's not going to know, it would be an African American person, but it's less likely than it was back in 2013 and early 2014.
Mm-hmm. I think for the His Health podcast, you've got all kinds of providers who are here for the same reason, but probably going to get so much out of what you're talking about. I think for the providers who are like a Theo Hodge, who are African American, in a field where they're a minority, speaking up for the needs of the community who needs this the most, but whose needs are often not being met. what kind of advice can you give them to stand your ground, especially when you're amongst folks who feel like they got it all figured out? Who are you from the outside, not a big name, quote unquote, to say whatever you're saying, but you know that you need to say it?
Right. I mean, for me, I have felt, because I had a growing process like anybody else. I mean, in medicine, as in any other field,
Yeah.
People give their accolades and they give their respect and attention to people who have, quote, met these standard.
How many NIH grants did you
right,
get?
Exactly.
How many PI titles do you have?
Exactly. How many times have I seen you on TV and blah, 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 blah. So to actually get up and say to somebody who has all of this and you don't, although you know that you've been out in the trenches, if you will, because those people up there in their ivory towers, it is really that way.
You're
for
not
many
seeing
of them,
patients as much.
they're
And
not
if you are,
seeing
it might be
patients. Exactly.
Yeah.
I know that I'm out there really seeing patients, and I'm dealing with, and I live with them too. So this is totally different, because I remind people all the time, if I'm out there recommending this and that in terms of your treatment, I really have to believe in what I'm doing, because I'm going to run into you. And the last thing I need is to be at Safeway and have your mama chasing me down the aisle saying, my child believed in you and I can't believe. We can't have all of that. So as opposed to people who fly in, see the patient, and fly out, and they're living somewhere else.
Right.
So with that knowledge, after having done this for so many years, I don't have a problem telling people, look, I don't care. And when they give me attitude, oh, child, you ain't never seen attitude with these arrogant people who think they know it all. Then you're like, look, you may give attitude, you may throw, whatever, but here's the simple truth. This is what I am seeing in my clinical practice.
I don't need a study
and
to verify it. Yeah.
Value. And whether or not you pay attention to me, then that's your loss. I will go to somebody else who will pay attention, because your job is to actually work together with other healthcare providers to enhance the care of the patient. And if you're so arrogant that you can't understand that, trust me, there's somebody else I can talk to. And I've actually had to tell people that. Because, oh my God, some of my colleagues.
Yeah.
Now, don't get me wrong, I have some fabulous colleagues. You just look at them and you're like, oh, child, you are all that. And I tell them that. And I'm like, I really appreciate the fact that you're approachable, that you're knowledgeable, and that you actually get it, that we're supposed to be working together to enhance the care of the patient. Right. So I would tell any other healthcare provider, in terms of getting a message out, you need to stand your ground. You know who you are. You know what you've experienced. And you know that you're a good doctor.
I do want to have providers, especially there are going to be folks here who are specifically trying to get information about PrEP, because we know there are lots of providers who just sort of are on the fringes the way patients are, and they just kind of don't know. They don't know about how to prescribe it. They don't know how to sort of assess whether a patient is a good candidate. Can you give us a sort of who, what, where, when, why, how, the rundown on PrEP, how a patient needs to take it, and how to assess whether or not someone's a good candidate for PrEP?
Okay, well, there are many sources, as you know, to include the NASDAQ CME PrEP module.
Check it out.
Exactly.
Launching in the summer of 2016.
There you go. AIDS.gov, okay. They're fabulous, too. So, what the breakdown is, okay, so who's an appropriate candidate? Someone who is male or female. PrEP has been approved for males, females, those who are injecting drugs, particularly people who are not in a monogamous relationship and have had a STI, who are in a relationship with an HIV positive person, that is, they're negative and the person is positive, that is a discordant relationship. Sex workers. There are many things that would make the patient an appropriate candidate. So the next thing after that is to assess whether or not they're HIV negative. PrEP can only be given to an HIV negative patient.
And providers need to do what first?
And they need to do a test. Usually a 4th generation HIV test is what I usually recommend. If it's a 3rd generation, then it has to be confirmed with a Western blot. With men who have sex with men, and certainly I would screen for all the other sexually transmitted infections. One must also determine whether or not they have chronic hepatitis B, since the drug approved for PrEP can suppress hepatitis B, and if it's interrupted, there can be a horrendous exacerbation of the disease. patient needs to understand that PrEP is just one of the tools in the prevention box. It was meant to be used not in lieu of condoms, but in addition to condoms and or other preventative measures to prevent HIV infection. PrEP by itself is never, ever, ever 100% effective, and everyone must understand that. It is not 100%. Never has been. There's not been a clinical trial where that has happened where it's been 100%. Anyone on PrEP must understand that they also must do routine follow-up, usually every 3 months, so that we can assess, number one, that they are continue to be HIV negative, and then number two, they're not suffering any of the potential adverse side effects to PrEP, such as kidney disease. So those are the things that people need to understand about pre-exposure prophylaxis.
And what is the recommended sort of intake for PrEP for a patient? Like, how often are they supposed to take PrEP?
PrEP is to be taken every day. Mm-hmm. Every day. Adherence to PrEP is correlated to the efficacy of PrEP. So if you don't take the drug, then the drug is not going to work. It must be taken every day to offer the fullest potential that it will work.
Which is super important, right? Because we've talked about how you'll have a patient who's on PrEP, taking it routinely. For whatever reason, they stop. Then they come back to you and they're like, well, I'm going to go have an awesome weekend, Pride weekend in D.C. this weekend. And
I just had that happen.
You know, can I jump back on Friday and be good for all of the goings-ons for the weekend? Like, what does a provider need to know about how to handle that kind of question?
So you need to laugh and say, that's so cute, you want that, but you're going to have to use something else other than PrEP. So, I mean, because the guidelines from Gilead, the makers of PrEP, they will tell you that, you know, first of all, we don't know how long it really takes. But in general, because we do have tissue levels, and when it does, you know, how long it takes to get to these tissue levels, the going line I usually give people is 3 weeks. So it takes about 3 weeks.
Taking it every day for 21 days.
Exactly, yeah. 21 days. So if it's Friday and we already know the festivities of DC Capitol Pride have started, and you just decided you're going to start your Truvada back,
should have hit it in mid-May.
Exactly. No, doll. You have to use a little more than just PrEP. So, yeah, 3 weeks is what I usually tell people.
I think this is really, really helpful for folks to sort of just get boilerplate, the basics of PrEP use and PrEP prescription. Let's now talk about the future of HIV with regards to all that's available. Where do you see the future of treatment for Black gay men going?
I see. Okay, so you know the National AIDS Strategy was updated not that long ago, and their big thing is that, you know, that HIV infection would be a rare event, and if it did happen, that regardless of race, gender, sexual orientation, that patients be able to access care and medication without any obstacles. So that is what I would like to see, particularly for African American gay men or men of color, and a decrease in infection, which will most definitely, and the National AIDS Strategy also says this, a role for PrEP. They're really big about, you know, PrEP is going to be and has to be an integral part of us actually achieving this mission that there is, you know, HIV infection, new infections being a rare event. So that's what I would like to see. I really think that in reality that's going to take time, because in real life, educating folks and then implementing programs that people can actually access PrEP.
Scale it up.
And then implementing programs to enhance adherence to PrEP, implementing programs that actually can follow people if there is an adverse side effect. Because, I mean, again, I tell people, you know, these things can happen, and well, in real life, they do happen. So it's a rare, it's uncommon, but they happen. And so you have to have all of this infrastructure in place to actually deal with that. I see it coming. I think public health departments are looking at this going, we can make a difference in health. So they're allocating money to start PrEP clinics, and they're starting to say, okay, what if somebody has a kidney function, linkage to care to a nephrologist, or, you know, what if they have a bone problem? The same thing, maybe an endocrinologist. But they take time. And, you know, my hope is that these will occur in an expeditious manner rather than the slow way that they can happen.
Yeah. And where do you see your future?
My future. I often wonder that.
Besides the log cabin this weekend.
Yeah, log cabin is such a wonderful thing, and I love my Law and Order reruns. I just love it. And I want to travel. Okay, but back to back to my real reality here. Right now it still flips my switch to get out into the community and educate. I love talking to audiences where I feel like I've made a connection. And I've had that opportunity, where I get in there and I talk about real things that are going on and engage the audience so that they actually are listening to me. And they're like, oh, okay. I tell people all the time, no matter what I'm telling you, it's so cute. It may sound smart and I can do this reference and that reference. But the whole thing is there anything that you're saying that I actually can bring back into my reality? Mm-hmm. Does anything you say resonate with me?
Yeah.
And that is my goal. I don't like doing talks where I know ain't nothing I could possibly say to you that's going to resonate in your world because it ain't going to ever resonate in mine. So I don't do those kind of talks. So for Theo Hodge, I really feel that speaking and education is still a wonderful thing that floats my boat. And I'd like to do more of that. Don't get me wrong, I like seeing my patients. I really do. But going to the hospital, won't do that anymore. That I leave to my hospitalist colleagues. Because I would be in my office all day and the hospital all night. And we can't do that. Mm-hmm. So there are things that over time I have let go. Because when I started, I was in the hospital and I was in my office. And I didn't have much of a social life.
I was about to say.
Right.
Yeah.
It wasn't cute. And I was like, let's see, what am I going to have to let go? Oh, the hospital, because the outpatient stuff was so busy. And, we had the advent of the hospitalist. We didn't have hospitalists when I first came into medicine. There wasn't a specific physician who only took care of patients in the hospital. I had to take care of my patients in the hospital. Now, I would be a little more concerned about me taking care of somebody in the hospital because I don't do hospital medicine. It's always
different.
It's very different.
Private practice, yeah.
Very different than outpatient medicine. Mm-hmm. So that's where I see myself at the moment. One day, all this gray hair. I do have dreams of retiring, and I figure that maybe I'll morph over to the VA, which is where my heart is, because that's where I did a lot of my training, and I am a vet now, and I'll take care of the older patients, because our population is aging,
yes.
And they're aging with me. When I was in my mid-30s, so many of my patients were in their mid-30s, and I'm not in my mid-30s anymore, but, people have aged with me, so I'm figuring that, I will at some point move from private practice to a different setting than I am right now.
I think wherever you are, you would be a absolute treasure. I can't tell, it has been such a wonderful experience working with you. I won't get all mushy on the podcasticles, but that sounded weird, but... But you know what I mean. I've learned so much from you. It's been an absolute pleasure and joy, and we're incredibly blessed and thankful to have you be a part of the His Health podcast. Can we find you on social media anywhere that you would like to share, or should we just catch you at the speakers bureaus? I feel like you're everywhere.
Oh, well, I don't know. I am on Facebook. Who knew I was on Facebook? I didn't know it. I had no idea that people use Facebook. I had not a clue.
His Health has tagged you all up and down on Facebook.
So yes, I am on Facebook. It has been an experience. It really, and I must echo that this has been a fabulous experience.
I'm glad.
Thank you for allowing me the opportunity to participate, because as I say, education really does float my boat, and I really mean that. So thank you for allowing me that opportunity.
Thank you for being a part and being so down to let this come out on all the channels, podcasts, social media, CMEs on phones, etc. Hishealth.org will be launching in late summer, and you can find you can find Dr. Hodge's podcast and his amazing CME interactive online video as well on the resource. Dr. Hodge, thank you again for joining us. That concludes this episode of His Health.